dear attendees, dear friends. Thank you for joining us tonight to this our scientific advanced medical retina webinar. And it's my pleasure and my honor to present two eminent speakers, colleagues and friends. Dr. Sibel Demirel from Ankara, Turkey. Dr. Sibel is Associated Professor of Ophthalmology in Ankara University Medical Faculty Department of Ophthalmology, and she is visiting scholar in Nebraska Medical Center, United States of America, and the board member of the Young Ophthalmologist and Retina Imaging Society, and she published many articles in peer-reviewed journals. And the second speaker, Dr. Daniela Bacherini from Florence, Italy. She is a researcher in the University of Florence, the eye clinic. She completed her ophthalmology residency and PhD in neuroscience at the University of Florence, and with a particular interest in medical, surgical, retina, and retinal imaging. And she is an active participant in clinical trials, and she published many articles in peer-reviewed journals. And in our agenda today, we will discuss two main interesting topics. The first one will be presented by Dr. Sibel, how to manage the CNV in pachychoroid disease. And the second one will be presented by Dr. Daniela Bacherini. Is there any role of OCTA in surgical vitreoretinal diseases? And please, if you have any questions during the meeting, just either put it in the chat box or raise your hand, and you can ask the speakers directly. Thank you very much. Dr. Sibel, the stage is yours.
Okay. Now I'm sharing my presentation.
Yes, please.
From the desktop. Is that okay?
Yeah. Okay.
Is it good?
Yes,
yes, that's good.
Okay, okay.
Yeah, okay.
Hi, everyone. Good evening to my colleagues, dear colleagues, and my friends from Turkey and abroad. And I would like to special thank to my dear friend, Dr. Fawaz, for inviting me and making this webinar possible. What I'm going to today is a brief introduction about pachychoroid disease and showing some cases treated with photodynamic therapies for the diagnosis of pachychoroid neovasculopathy. And finally, I am going to give some my take-home messages supporting this treatment in this disease. Let's start with the first slide. After initial report in 2003 about pachychoroid pigment epitheliopathy and the 2015 pachychoroid neovasculopathy, the worldwide interest for this disease seems to grow. And right now we have 156 published articles in PubMed or listed on PubMed. This is, I can say easily that this is a very hot topic in medical retina area. Let's start with the definition of the disease. A pachychoroid spectrum reflects a group of clinical situations that have a common characteristics of a thickened choroid or thick choroidal vessels, which is called pachyvessels, and share an underlying pathological mechanism. Those are the different examples for this disease in the same spectrum. For example, first one is showing pachychoroid pigment epitheliopathy cases. Second one is an example for focal choroidal excavation. Third one is example for central serous choroidopathy. And as you notice that all of them have thick choroids under this pathology. As a definition, after the term pachychoroid was introduced by Barrow and colleagues by a group of the retinal physician in New York, Bailey and group, to describe a group of macular diseases presenting with a thick choroid and generally defined as subfoveal choroidal thickness exceeding 300 micron, or the thickness of any extrafoveal choroid location, nasal or the temporal, not important, in any location is 50 micron bigger than the thickness of the central choroid. And another feature is that dilation of outer choroidal vessels, which is called pachyvessels, as I said before. And these vessels, these big vessels is usually located in halar layers. And thinning of choriocapillaris and subtile layers located on dilated big choroidal vessels and direct contact in between the big halar vessels and the Bruch membrane is another feature of this spectrum. Finally, increased permeability of choroidal vessels depicted by ICGA, another good feature of this disease. We all use ICGA or EDI OCT or web source OCT for the diagnosis of this disease. We have many diseases under the spectrum, as I mentioned before, and actually the numbers has been increasing since recent years. At the beginning, we have just 4 or 5, and right now we have 7, maybe 8. But our focus will be pachychoroid neovasculopathy today in this webinar. That's why I will skip to mention another disease under spectrum, unfortunately, because of the time issue. We have been aware of the definition central serous choroidiopathy for many years. And under the spectrum, we know with the help of the ICGA and recently after the evolution of optical coherence tomography, such as EDI, optical coherence tomography or the web source, thick choroid was well recognized in this disease, indicating choroidal pathology in central serous choroidopathy. So then, pachychoroid definition came in 2003. Why we proposed this new definition for this disease that has thick choroid? Why people or retinal physician noticed new, different from central serous cases and defined them as pachychoroid neovasculopathy? I think this is the big question at the beginning. As we all know that since the advent of excellent imaging technique with good resolution, people noticed that many abnormalities over these thick pachychoroid or pachy vessels. One of them is, for example, RPE abnormalities on this area. Here, can you see my arrow on the screen? Fawaz? Fawaz, can you see my arrow on the screen?
Yes,
okay.
we can see.
Yes, doctor.
Okay. For example, one of them is RPE abnormalities on this area, which was called pachychoroid pigment epitheliopathy. But more important one, people noticed that flat irregular pigment epithelial detachments in thick choroid patients characterized by double layer sign. One of them is Bruch membrane, the other one is RPE layer, and very shallow pigment epithelial detachment with some internal hyperreflectivity. And we already know that this irregular PED is one of the most common characteristics for occult choroidal neovascularization in AMD cases. However, it is not AMD all the time. And the question is that we have a new thing, thick choroid, thick hilar lateral layers, and over it we have choroidal neovascularization. What is it? Is this a lesion, an occult choroidal neovascularization secondary to AMD? Might be, because some people have mild thick choroid when they are young, and then they may develop in the future when they are an older age, AMD. Might be, but it is unlikely because these cases usually younger than the age of AMD cases, and they don't have drusen or any other characteristics typical for AMD. Another possibility is that is this lesion, this flat irregular pigment epithelial detachment, subretinal fluid, etc., and the thick choroid, CNV associated with CSC is another possibility. It can be. If these patients don't have any previous central serous attack, what if it can be? This is another possibility. Then how you call these patients? There is a gap in between this disease, and we don't have the good name, the correct name to diagnose with these cases, to define with these cases at that time. So the question, the paper came up in 2000, and as an answer, this paper came up, and it's published in 2012 in Retina Journal, published by Yanuzzi and group and Bailey, and they noticed that they noticed something. There are two type of cases. First, people have type 1 neovascularization in central serous choroidopathy, and second one, they have type 1 neovascularization who have thick choroid but didn't show any AMD characteristics such as drusen. Still, they didn't name it pachychoroid neovasculopathy in that time, but they defined them. Probably they are different from the regular AMD cases As you see here, because they are relatively younger, mostly men, and they have a higher prevalence of PCV than those type 1 CNV in AMD. But I would like to emphasize again, they didn't name it pachychoroid neovasculopathy in 2003. And as a conclusion, they told us this situation might be a masquerade for AMD cases or vice versa. The definition came from the same group in 2015 and published in Retina Journal at the same time. And as a definition, Bailey and the colleagues defined this pachychoroid neovasculopathy is a new clinical spectrum of these diseases characterized with increased choroidal thickness. See here these huge choroidal vessels, hilar vessels, or thick choroid under this area, and type 1 choroidal neovascularization over it. As you see here, there are hyperpermeability and the big choroidal vessels all along the macula, and in the center there is a plaque appearance which is characteristic for type 1 CNV. When I took this optical coherence tomography image from the patient, you can easily notice that there is a tangled network, filamentous network in the center. So we have a definition and name right now. However, there is a big controversy right now. There is a big debate right now. No one knows what is the difference in between, even if the most of the big authors who are interested in this issue. Pachychoroid neovasculopathy versus central serous chorioretinopathy cases complicated with choroidal neovascularization. What are the differences and similarities in between? Are they same or are they different? But as we all know that from the first definition, from Bailey and group, they defined pachychoroid neovasculopathy if the patient, they don't have any previous attack, any previous fluid from central serous chorioretinopathy. But is it possible to differentiate all the time? I don't believe that, because patients might not be aware of previous attacks. Some of them just came to your hospital for the first time and then explain his symptoms. And when we ask about the previous history of the disease, usually they say none of them. It was the first time. Also, gravitational defect can be seen in chronic central serous. We all agree, but it is not a rule. Some people don't have these characteristics, features, or imaging features all the time, even if they are diagnosed with chronic central serous chorioretinopathy. And some CNV cases with chronic fluid might have this sign as well. So this is not, how can I say, this is not a must for these cases. So overall, this is not always easy to understand whether or not the patient had previous attack of central serous or not. That's why the topic is still debatable. We don't know the difference between the CNV, complicated CSC, and the pachychoroid neovasculopathy. These slides for the brief introductions. However, this is not the discussion for this webinar. My topic is not imaging, and that's why I just wanted to make a brainstorm to think about it at first, to get familiar these entities. And right now, I will go forward with my cases and showing some treatment results of photodynamic therapy in these cases. Case 1, 46-year-old male. He was diagnosed with central serous for 10 months. The visual acuity 0.7. As you see here, a leaking area in the paracentral fovea, and corresponding to that area in the ICG image, still leaking area showing hyperfluorescence, and around it there is some hyperfluorescence plaque, maybe due to choroidal neovascularization or choroidal hyperpermeability. I was not sure about the diagnosis, which I believe that this picture was not typical for type 1 neovascularization like I see in AMD cases. But of course, I had a suspicion about the choroidal neovascularization, but I believe he was a pure central serous cases. This is a typical for, the fundus autofluorescence picture. There are some hyper autofluorescence spot coming from the center and going down to the periphery. and you can name it gravitational defect if you have some RP changes over it. Nothing but subretinal fluid here, no pigment epithelial detachment, thick choroid, and the diagnosis was pure central serous, and I decided to photodynamic therapy for these cases. See the difference. This is the post-treatment immediate after the treatment result. There was total resolution, no subretinal fluid, and if you notice that the thickness of choroid decreased significantly after the treatment. However, this is a surprise. Back then, we didn't have optical coherence tomography angiography machine in our clinic, and after 20 days from the treatment, we had it, and I immediately called him back to come to hospital and get this picture from him to understand what is happening there. And it was surprising. There was a choroidal neovascularization in the center, but even if this choroidal neovascularization, you see the 3 months later and 1 year follow-up, no recurrence, the visual acuity increased to 1.9, but still choroidal neovascularization existed in all follow-up visits. And here in the 4 years follow-up, the visual acuity 0.9. The patient is very happy about the results. And I have been following these cases now with frequent follow-up visits. And as I mentioned before, still this silent tangled network in the center, but it didn't cause any leakage or activation right now. After 4 years, I think it's a pretty good result. For 4 years, without any treatment, we followed these patients with without any anti-VEGF injection or any other PDT treatment, and he has been stable for 4 months without any fluid. This is case 2, 57-year-old male, again male, visual loss in his right eye. He came to our clinic with decreasing visual loss, visual acuity 0.5. In the B scan, subretinal fluid, shaggy photoreceptor layers, outer segment of the photoreceptor layers, and there are some cysts in the nasal part. Also, the choroid is thick here, as you see here. In fundus autofluorescence, another typical finding for chronic central serous choroidal retinopathy, this hyper-autofluorescence area due to chronic fluid coming from the center and going to vascular arcade. In this FA, some RP abnormalities at the beginning, and that's all. All I have these pictures. And at that time, I was not aware of the definition of pachychoroid neovasculopathy too much, 5 years ago almost. And at the beginning, I got stuck between about the diagnosis between central serous and age-related macular degeneration, since the patient is 57. Would it be central serous choroidopathy? Of course, it could be, because choroid is thick. There is a hyperautofluorescence in the fundus autofluorescence picture, and some RP defect and maybe leaking area in the FA. However, unless it is chronic, intraretinal cysts are unlikely seen in chronic central serous cases. However, the patient had acute symptom, acute decreasing of the vision on his right eye. Another possibility, age-related macular degeneration. Subretinal fluid and intraretinal cysts are likely seen in AMD, we all know that, but he doesn't have any drusen, no hemorrhage scar, any appearance of choroidal neovascularization under RP, above RP, etc. And the choroid is thicker than normal. So I had a suspicion about central serous, but I was not sure at that time, and I started with anti-VEGF injections. This is the before, and after 3 ranibizumab, 5 ranibizumab, yes, there was subtotal resolution of the subretinal fluid, but after 5 months, we have still subretinal fluid in the center. And then I decided to switch another drug, aflibercept. I started with 3 loading doses, and the results was pretty good, actually. However, when I continued with continuous anti-VEGF injections, the situation was getting worse, and you see the cystic spaces and fillet irregular pigment epithelial detachment in the end. And I decided to do something more, for example, PDT. And before PDT, I usually get a picture of ICGA from the patient. It is always what I do that for these patients. As you see here in ICG picture, corresponding to that area, this RPE changes corresponding to that area, there is a big hilar layers like a C shape, and in the late phase, just next to it, there is a plaque-like appearance suspicious for choroidal neovascularization. However, I did my PDT treatment as a half-length PDT. As you see here, this is the before treatment, this is the after treatment, a month after the treatment. There was total resolution. All cystic spaces disappeared after treatment. You see this disruption of the outer retinal layers and some RPE atrophies corresponding to that area, whatever, but the patient was doing well at that time. The visual acuity increased to 0.5. Unfortunately, it's 0.5 because he had already had these RPE changes and disruption of the outer retinal layers, but he was very happy with the results. And here you see the choroidal neovascular network in the parafoveal area, which is silent in this place. So guess what? How long the patient remains stable without any treatment? He is almost 60. He has choroidal neovascularization, and he had got many anti-VEGF injections at the beginning. However, he was getting worse. But finally, after one PDT session, he has been stable for 4 years without any treatment. I think it's pretty good result for this case, and he's very happy with the result. But of course, the choroidal neovascularization is still there, but it's silent. Another case, 53-year-old male diagnosed with central serous for 10 months, the visual acuity 0.8. And he came to our hospital for seeking treatment, and he already knows the PDT treatment for this disease. This is the all pictures I have at the beginning. There is subretinal fluid, very shallow, I can say, very shallow flat irregular pigment epithelial detachment over that pachychoroid vessels, and infundus autofluorescence in the center, slightly increased hyperfluorescence due to chronic fluid in the subretinal space. And in this dye angiography in the parafoveal area, RPE changes and showing window defects, and in the late phase, a little bit leakage. When I see my picture on my ICGA picture, at the beginning there was nothing, and the late phase, maybe here there is some hyperfluorescence secondary to hyperpermeability or CNV, who knows, because it was not obvious. I usually appreciate this plaque appearance in AMD cases as a very prominent vascular plaque in the end. But for this case, I couldn't see this appearance for this case. I did PDT again for these patients. This is the immediate result after post-treatment. You see the fluid had gone after the treatment, and I have been following these patients almost 14 months, and the visual acuity increased 1.0. Patient is very happy. The center is healthy. The continuity of the outer retinal layers are perfect, and that's why the vision increased to 1.0, and the patient is very stable right now after one PDT session, even if, the surprise, he has 2 different choroidal neovascular plaque in the beginning. Even if I already knew there are 2 different plaques in the OCTA images, I never changed my idea about the treatments. I decided to treat these patients with PDT, even if I know already he had some choroidal neovascularization in the macula. And this is the final result after one PDT, half-length PDT. Still, he has choroidal neovascularization in different 2 areas. One of them is here, the other one is here. and he is doing well without any recurrences and with full visual acuity. The tricky one for the fourth case, he's a neurosurgeon, 42-year-old male, diagnosed with central serous for 8 years, and I was the first doctor to diagnose him as a central serous choroidopathy 8 years ago. And at that time, I didn't know the diagnosis of pachychoroid neovasculopathy because it's published in 2015. And also, as far as I remember, I didn't use PDT for these cases, because of some technical issues. I offered one anti-VEGF injections 8 years ago. He accepted it, and then we lost the contact because he believes that he can manage these patients with some healthy lifestyle, etc. And after 7 years, 8 years, he came back to our hospital. This is the picture of 8 years ago. There is a leakage here, just tiny little bit leaking area in the parafoveal area. And this is the new current pictures of him. In the previous area, there is RPE changes, and there is a new leaking area in the superior temporal parafoveal area. Corresponding to that area, there is just some big hilar vessels not tapering in the macula center, which is typical for pachychoroid cases. So no plaque, no any other thing, no obvious hyperpermeability, but just in the center on ICGA, these choroidal vessels are obvious, huge choroidal vessels not tapering in the center are seen in this picture. This is B scan optical coherence tomography. There is subretinal fluid here, some shaggy photoreceptors here in that place, and a little bit bumpy area over that big hilar vessels, which is called pigment epithelial detachment, of course. And just under it, please see that area. This is a big, huge choroidal vessels directly contacting with the Bruch membrane. There is no choriocapillaris or sacral layers in between. And no surprise, he had choroidal neovascularization in the center, some filamentous tangle network, and also in this B scan, there is a flow inside it, which means it has choroidal, the patient has choroidal neovascularization in the center, which is obvious on ANFAS optical coherence tomography angiography picture. So I offered him photodynamic therapy, and he accepted. But before I show my final picture, after treatment picture of him, I would like to emphasize something about the imaging. This paper, we published this paper in 2017 and in Progress Archives Clinical Experimental Ophthalmology. And we show that the optical coherence tomography angiography is superior to show choroidal neovascularization in this specific type of diseases, which is pachychoroid disease. Because normally, for type 1 choroidal neovascularization, ICGA is the gold standard. We all know that, for AMD cases especially. But usually what I see in AMD, in the late phase, definitive plaque appearance or hot spot in the late phase, usually we appreciate that. However, for these cases, since we have already choroidal hyperpermeability under this choroidal neovascularization, and it is shown as a hyperfluorescence in the ICGA, we couldn't recognize this plaque appearance over it, or another possibility, these are not, this choroidal neovascularization is benign when we compare this, their appearance from AMD cases. Probably they don't leak too much, they are silent, their behavior is different from AMD. That's why we couldn't appreciate this plaque appearance in every case. I showed 4 different cases to you, and none of them has obvious plaque in the late phase of ICGA. And that's why I want to emphasize that if you have this imaging modalities, please use it to make a good diagnosis, proper diagnosis for these cases. If you don't have a dye angiography, it doesn't matter. This is the final picture of him. He sent me this picture from another hospital elsewhere, because during these corona days he didn't came to my hospital for a regular follow-up, but his vision increased and he's very happy with the result, and his metamorphopsia decreased prominently. Another thing about my treatment, we always use half-full-length PDT for these cases in our department. We already know that from the AMD studies, full-length PDT has some side effects such as RPE atrophy or sudden visual loss or choriocapillaris closure. However, we know that from the studies, half-length protocol for central serous cases are very safe. We have been aware of this for many years, and with this sophisticated technique such as optical coherence tomography and B-scan optical coherence tomography angiography and the B-scan optical coherence tomography and some specific software, we demonstrated that even after 1 month, even if the 1 month after the treatment, choriocapillaris perfusion better than the before. So we don't damage this choriocapillaris permanently. After PDT treatment, choriocapillaris will become healthier than before, probably due to decreasing of compression of these hilar layers and the thick choroid. This is the most striking one, I believe. Another case, almost 70-year-old woman, the visual acuity 0.6, and she was diagnosed with AMD in another center. As you see here at the beginning, subretinal fluid and flat irregular pigment epithelial detachment is here. And I started with the anti-VEGF for this lady. And at the beginning, there was subtotal resolution at the beginning. It was getting better, but after 7 months, still I have subretinal fluid, like the one in the starting picture. So I decided to change my treatment to another one. So I noticed this hilar layer here under this flat irregular pigment epithelial detachment area, and I switched my treatment to half-length photodynamic therapy. I did it, and after I did this time, and after I did my treatment for this lady, you see there was total resolution. The center of the macula is very healthy. There is a flat irregular pigment epithelial detachment in the parafoveal area, but since the center is very healthy and they are continuous, the outer retinal layers are very continuous with each other. That's why the vision increased 1.0, and the patient is very happy with the result. As a summary, 7 anti-VEGF injection in 8 months, 0 anti-VEGF injection in 7 months, and I was very happy with the results, because for 7 months I never used any anti-VEGF injection for this lady. Here is another case. Just 1 second. Yeah, this is the final one. Case 6, 43-year-old male diagnosed with central serous chorioretinopathy, and he had already 1 injection in Istanbul and came to our clinic for photodynamic therapy. Visual acuity was 0.5. At the beginning, he was not active. There was no subretinal fluid, any other things. Just I noticed this big choroidal neovascular membrane in the center, and the choroid is very thick, highly thick than the other case. And also, unfortunately, there are prominent, very bad RPE changes all over the macula and widespread all over the macula. This is because some of my colleagues try to follow these patients without any treatment, and that's why they can happen. And please try to do something more for these patients, because they are young. After and he had already 1 anti-VEGF injection, and he was not active at the beginning. And of course, I decided to just follow these patients regarding any recurrences in the future. So 7 months later, he came back with this fluid. The fluid came back, which I expected, because I know that anti-VEGF injection was not sustainable treatment, and I decided to do with photodynamic therapy. After 2 months, here is the result. There was total resolution. However, it came back again after 2 months. So I had one anti-VEGF injection for this subretinal fluid, and then it went away again, and the patient is stable now for 33 months. And as a summary, I have been following him almost 3 years, one PDT, half-freelance PDT treatment, and one anti-VEGF injection. The visual acuity is 0.5, unfortunately 0.5, due to these very prominent RPE changes at the beginning. I finished my cases, and before I give my take-home messages, I would like to share these 2 papers of ours, and I want to show you and discuss with you some morphological differences in pachychoroid diseases. We published 2 papers showing some differences between pachychoroid spectrum. The first one on the left-hand side, we found that the most compromised layer choriocapillaris is in the central serous group. We compared 3 groups: pachychoroid pigment epitheliopathy, uncomplicated pachychoroid, and the pachychoroid central serous chorioretinopathy, and we found that the most compromised choriocapillaris is in the central serous group, shown by optical coherence tomography angiography. And according to this result, one may speculate this disease might be different stages of the same disease turning into another, maybe, but just I'm now talking about these 3 diseases: uncomplicated pachychoroid, these 3 stages: pachychoroid pigment epitheliopathy and the central serous chorioretinopathy. The second paper just published 3 days ago, and we found some differences of choroidal morphology in some particular pachychoroid diseases, such as central serous chorioretinopathy and pachychoroid neovasculopathy. These differences were evident in asymptomatic fellow eyes. I think it's very important. We need further studies to understand these morphological differences, pathophysiology under this disease, to understand what is happening in this disease. Are they different, or are they the stages of the same disease turning one to another? And we need definitely further studies with these sophisticated imaging techniques, for example, optical coherence tomography angiography, or what I use for this paper, IMAGE-J, and BCAN optical coherence tomography angiography images. Sorry, this is the second paper, but I mentioned before. We published it 3 days ago, and it is related about the choroidal morphological differences fellow-wise of different choroidal disease. And in the end, my take-home messages. I believe that photodynamic therapy has a role for treatment choroidal neovascularization secondary to pachychoroid diseases. And proposed treatment strategies are right now for AMD and needed regular follow-up. Don't forget it. Treatment regimens of AMD, for example, treat and extend, PRN, monthly, 2 monthly, etc., might not fit for these patients, especially the young one, due to frequent follow-up visits. Adding PDT might help might prevent you from a lot of frequent follow-up visits and further anti-VEGF injections. And this is the end of my presentation. Thank you very much. Fawaz. Can you hear me? Fawaz?
Dr. Fawaz, just unmute yourself, please. We can't hear you. Still unmuted, doctor.
Okay.
Yes.
Now it's okay. Okay, so thank you, Dr. Sibel, for the wonderful, fruitful presentation about the pachychoroid disease. Before we open the question, I want to ask you. You showed us in your presentation that the best way to treat the pachychoroid neovascular CNV is the photodynamic therapy. Do we have any other options for treatment of pachychoroid neovascularization, since we don't have any approach to photodynamic therapy in Jordan?
Okay. First of all, I would like to emphasize that I believe central serous choroidopathy complicated with choroidal neovascularization and pachychoroid neovasculopathy are different. And
Okay.
PDT works very well for pure central serous cases, and central serous cases complicated with CNV. I always go first with PDT for these cases. But for the pachychoroid neovasculopathy, you need combined therapy, I'm sure, because some of them, you know, I combined with anti-VEGF, etc. So you need combined therapy. If you want to decrease your injection numbers, for sure you need photodynamic therapy. But if you ask me about micropulse laser, what I used for central serous cases, no, it didn't work in this issue because you have choroidal neovascularization. For choroidal neovascularization, you have to use anti-VEGF. If you use your PDT for these cases, probably you will decrease the thickness of the choroid and reduce the signal, VEGF signal and ischemic signal for this choroidal neovascularization. And that's why I believe it works for these cases.
Okay. In case of the PCV, do you recommend to start just with anti-VEGF, or we can also use the photodynamic therapy?
It depends on the patient. If it's located just peripapillary, for example, I usually started with anti-VEGF, and if I need photodynamic therapy, and I would go for with photodynamic therapy. But usually, what I prefer is combine the treatment at the beginning.
Okay, thank you very much. Now we open the questions for the attendees. Please, if you have any questions, just unmute yourself and you can ask questions. Tawfiq, you can help us. Is there any questions in the beginning of the chat box?
Dr. Fawaz, there is no question in the chat box.
Okay, so any raising
anybody
hands?
who want to ask, yes. No raises hands. And anyone want to ask, just unmute. He can unmute himself and ask the question directly.
Yeah.
Good evening to everyone.
Good evening.
Thank you, Dr. Sibel, Dr. Fawaz, everyone, for this presentation. I'm Dr. Mohammed Al-Janabi from Jordan. As Dr. Fawaz mentioned, we don't have access to PDT. So if I may ask Dr. Sibel, if you have any experience with the using of oral agents such as methotrexate or rifampicin or other agents that may work for chronic CSR cases. Thank you so much.
Yeah, you are welcome, my friend. I don't have any experience regarding oral, any supplements, drugs for these cases, even if eplerenone, because I believe PDT works very well for this case. Or you can use micropulse laser if you have in your clinic. It is not damaging laser. It is not damaged retina. Very comfortable. You can do it, and you can repeat this treatment after first treatment for many times, and they didn't cause any permanent laser spots in the central. It works well as well. But what I suggest you to use photodynamic therapy, either photodynamic therapy or micropulse laser for these central serous cases. I don't have any idea about other drugs, but as far as I know, we have a very well randomized control prospective studies from England, and according to that studies, eplerenone is not beneficial for these cases. It's just a placebo.
Okay, thank you very much. Just I want to ask you, Sibel, in the cases of acute CSR, did you treat sometimes the patient with acute CSR? For example, sometimes we're facing the patients with a high visual demands, and when we told them that you need to wait for 3 months, they usually said that I cannot wait, I need treatment. So did you sometimes treat the patients with acute CSR?
Yeah, sometimes. Yeah, I did.
Yeah.
I do. Yeah. Because I have a very good weapon for acute cases, for example, such as micropulse laser. which is very safe. I usually wait for 3 weeks, 4 weeks. If the patient first come to me and another without experiences of attacks. So I usually wait for 3 weeks, 4 weeks, and then I try to maybe 1 month more, but that's all. I usually go first with micropulse laser. And if it's chronic case, I usually prefer to do vitrectomy.
Even the leakage within the central 500 micrometers?
Yeah, no, you are not treating the leaking point with micropulse laser. You are treating the place which is thickened due to chronic subretinal or acute subretinal fluid. You just induce the RPE to reabsorb the fluid. So this is not like the one what we use in argon laser. We are not using treat the leaking point.
Yeah, this is the point that I want to highlight, because sometimes there will be a mix between the laser, the normal laser, and the micropulse laser, because the idea is completely different. Because here we are not photocoagulate, we are photostimulate. So this is the principles completely
you can spare 300 or 500 micron in the center and use your laser like a grid fashion in the macula center, and that's all.
Okay. Daniela, if you have any questions to Sibel regarding the CSR, and if you have any different experience in treating the chronic CSR cases. Unmute yourself, Daniela, maybe.
Sorry.
Sorry.
Okay, congratulations, Sibel. Wonderful presentation. Thank you so much. Just a question. Do you study the endogenous cortisol profile in patients with the central serous chorioretinopathy? I have some colleagues that make a dosage of cortisol, urinary cortisol during 24 hours. What do you think about it?
Actually, I have no idea about this. As in theoretical part, we already know this endogenous high cortisol level or symptomatic activities can cause this disease and make the hilar vessels more dilated and congested, and that's why they can cause choriocapillary ischemia. But I don't have any idea about that paper. Also,
I don't assess it. So I just do. And what do you think, Fawaz, about? Do you assess this aspect? Do you study?
Actually, not.
Okay.
We didn't study the cortisol level for the patients with the chronic CSR. Okay. So if you have any further questions before we shift into our second part, please, any of the attendees you want to ask, just unmute yourself. Okay, so we shift to the second part of this scientific webinar that will be presented by Dr. Daniela Bacherini, and the topic is there any role of OCTA in a surgical vitreoretinal disease? Dr. Daniela, the stage is yours. Just upload your presentation.
Thank you so much. Can you see my presentation?
Yeah.
Okay. Okay, thank you. So good evening, everyone. My thanks to Fawaz for the kind invitation. It's a pleasure and honor to participate in this webinar with my excellent colleagues and friends. In this, we are in a challenging moment of anxiety, general crisis and distance. So I think that this option of a webinar is also a way to stay connected and close. So really thanks, and thanks to the sponsor. As we know, OCTA has improved our insight into some diseases, mostly vascular diseases. But is there a role for OCTA in vitreoretinal interface, vitreoretinal macular disorders? It is well known that vitreoretinal interface disorders are a heterogeneous group of diseases with various grades of severity. And as we know, vitreoretinal interface disorders are not primary vascular disorders, but the consequences of an anomalous posterior vitreous detachment, which has been the unifying concept in this type of diseases for many years. And for many years, of course, the first big challenge was and still is to visualize the vitreous and its relationship with the vitreoretinal interface responsible for the alteration seen before. And of course, the OCT technique has also allowed us to improve vitreous visualization in a non-invasive way, and to date, it represents the fundamental imaging technology for VRI disorders. And the introduction of OCT in clinical practice has dramatically increased, as we know, the ability to diagnose the abnormalities of the VRI by providing subclinical information and allowing us to visualize, classify, and follow up these disorders. And thanks to OCT evolution, we have reached an excellent visualization of the vitreoretinal interface, even intraoperative OCT visualization. So today we can talk about multimodal imaging. Thanks. Can you hear me?
Yes, Doctor.
Okay, sorry. We can talk about multimodal imaging thanks to the integration and the combination of different imaging modalities. And this provides an enhanced visualization of a VRI and a better understanding of the diseases in terms of both the diagnosis and the management. We can differentiate the multiple imaging modalities in surgical vitreoretinal disorders according to the time they are performed in preoperative, intraoperative, and postoperative imaging, where each of these techniques can provide different and useful information. But regarding the preoperative prognostic factors to date, we know that most of them identified for VRI surgery have been proposed based on cross-sectional, structural cross-sectional B-scan OCT. Although these are widely accepted as helpful biomarkers for predicting visual acuity, visual outcomes following epiretinal membrane and macular hole surgery, the results for this predictor vary across the studies. In fact, although we have a similar preoperative structural B-scan OCT parameters, sometimes we get very different functional outcomes. So maybe preoperative cross-sectional OCT parameters are not enough to fully explain the different visual outcome. And this is the same for epiretinal membranes. Therefore, we need to evaluate the VRI from different points of view. And today we have many techniques that permit this. Focusing on the OCT angiography, it has brought us into a new era of diagnostic retinal imaging, as we know. In fact, it permits in and the choroidal vasculature, evaluating it layer by layer. Today, as we know, OCT angiography is mostly used in medical retina for neovascular macular diseases, occlusive retinal diseases, diabetic retinopathy, and the spectrum of Pachychoroid, as we have seen. And so why should we use OCTA in macular surgery for non-primary vascular diseases? First, to study with a non-invasive method the alteration in different and specific vascular layers. Second, to give us some potential prognostic factors, and we can think that information from OCTA could be useful not only in vascular diseases but also in non-primary vascular disorders. So let's start with the role of OCTA in epiretinal macular membrane. As we know, OCT is important to evaluate the integrity of outer retinal layers before surgery in case of epiretinal macular membrane. And since the analysis of the of outer retinal alterations may not be sufficient to predict the postoperative visual outcome, the attention has recently shifted to the study of the inner retina, that is the primary affected site of ERM-associated mechanical stress. And in this beautiful paper, Govetto et al. Described the presence of a continuous ectopic inner foveal layers in the central foveal region and proposed a new OCT-based grading scheme for the epiretinal macular membrane. Today, OCTA gives us the possibility of having a quantitative and a qualitative evaluation with the possibility of measuring the vessel density and the foveal vascular zone. So we can do a qualitative and a quantitative analysis using OCTA before and after epiretinal macular membrane surgery. The qualitative evaluation allows us to see in superficial capillary plexus, SCP, vessel tortuosity induced by epiretinal membrane, vascular congestion, and the non-perfused areas in the DCP. We can see a case of epiretinal membrane compared to an LTI, and we can see the OCTA shows above all a vessel tortuosity in the superficial capillary plexus. In this case, we can see also a vascular congestion in DCP. And another finding we have often observed in the deep plexus is the presence of non-perfused areas, also already described in literature. So we can see an OCTA grading scheme according to B-scan OCT, which shows in stage 2 a reduction of the phase, in stage 3 an absence of a phase and severe deformation and displacement of the vessels, and in stage 4 we can see many artifacts due to a severe deformation and the displacement of the vessel. And after surgery, OCT angiography can show us the restoration of a correct angioarchitecture with a reduction of vessel tortuosity mostly visible in superficial capillary plexus. As we know, OCT angiography gives us the opportunity of study vessel density. We can see this example of a panoramic reconstruction where we can see an increase of vessel density mostly in deep capillary plexus after surgery. But as we know, the OCTA gives us the opportunity to make an objective evaluation of the size and the shape of the phase. And we know that the central macular thickness is a critical factor and is correlated with the size and the shape of the phase. In other words, thin fovea has a larger size of the phase and a circular shaped phase, and the thicker fovea has a smaller size of the phase and an irregular shaped phase. OCTA so can be used to evaluate the foveal morphology in epiretinal macular membrane patients, and many studies demonstrated that the preoperative superficial phase area is negatively correlated with the central foveal thickness, and the area of the phase was smaller and the central foveal thickness. In the case of epiretinal macular membrane, we can see many phase changes. The phase is more irregular, is smaller, and often it could not be visualized. The results for the phase analysis are different between studies, but most of papers shows that the phase is smaller and the central foveal thickness is thicker in the eyes with epiretinal macular membrane, and that this difference was still present after surgery. So in any case, many authors point out the importance of examining the phase area to evaluate the effects of an epiretinal macular membrane on the structure and the vasculature of the inner retina. Other authors proposed the preoperative phase area ratio as a significant predictor of postoperative metamorphopsia. And so many papers, many authors evaluated the phase morphology in epiretinal macular membrane patient and the vascular density before and after surgery. This paper confirms that phase was significantly smaller in eyes with epiretinal macular membrane, and that a smaller phase was associated with worse postoperative visual outcome, showing that postoperative eyes with a larger phase area had a better prognosis of a visual outcome. One possible explanation is that epiretinal membrane removal relieves retinal mechanical traction from periphery to center and improves macular vessel distortion with which a large phase area, normalizing macular morphology and improving visual acuity. On the other hand, we have diabetic retinopathy, where the phase is commonly enlarged, and the grading of the enlargement of the phase is correlated with diabetic retinopathy severity and visual function. So a larger phase in diabetic patient is correlated with a more severe diabetic retinopathy and a worse visual function. OCTA can show us the effect of peeling, ILM peeling and ERM removal also in diabetic epiretinal membrane. We can see in this work that the deep phase area significantly increase after ILM peeling. On the other hand, postoperative angiographic changes were not significant using OCTA in idiopathic epiretinal membrane. So, we have to consider that it could be very useful, important to evaluate the phase in diabetic patient affected by epiretinal macular membrane before and after ILM peeling. We have to consider that in patients affected by diabetic retinopathy, there is an increase of phase area that correspond to a reduction of vessel density that increases with diabetic retinopathy severity. So in this patient, we have to know that macular ischemia is predictive of postoperative visual function. So this is very important because OCTA can show us some insight about macular ischemia in this patient. Moreover, we can study using OCTA the microvascular changes after vitrectomy with ILM peeling. We can see a reduction of vessel density also in the superficial capillary plexus. Many authors studied the effects of ILM peeling after on the deep and phase deep plexus and on the phase area. We can see very early changes such as vessel tortuosity reduction, and on the other hand, we have a longer effects with macular perfusion density recovery that need a longer time, likely due to a gradual and progressive reopening and the recanalization of microvessels. But as we know, all that glitters is not gold. So in fact, we have to consider that patients affected by epiretinal macular membrane are more likely to show motion artifacts on OCTA lab. Distortion of the foveal architecture often induced by epiretinal macular membrane. And how can the study of a vascular plexi using OCTA can help the surgeon in case of a macular hole? In one of our previous papers, we have analyzed the qualitative findings associated with the macular hole assessed by means of OCTA. We described the presence of cystoid cavities in deep plexus, and we saw that the mean cavity areas in superficial and deep plexus were significantly correlated between OCTA and ANFAS images. And the retina surrounding OCTA can show us that the retina surrounding the cystoid spaces preserve circulation, showing a vascular sliding. And this is important because this suggests that in full thickness macular hole, there is a preservation of microvasculature surrounding the cystoid spaces during the disease process. Many papers have reported on findings in macular hole after the surgery, and OCTA has demonstrated that eyes after macular hole have highlighted the resolution of the macular hole and the cystic areas, a reduction of the vascular density in macular and the paramacular vasculature, mostly in deep capillary plexus, a reduction in the phase area, and an increase in choriocapillary vessel density. We can see that using OCTA, we can observe the recovery of the angiarchitecture after surgery very well without dye. Differently from the epiretinal macular membrane, as we saw, in macular hole, a smaller postoperative phase area seems to be correlated with a better visual outcome after surgery. So phase area was correlated with the postoperative area. So eyes with a smaller phase in case of macular hole after surgery may have more neural tissues filled in the macular hole, and so this can lead to better central visual function. And many authors proposed that the phase area may be one of the several possible surrogate markers, biomarkers for representing the integrity of the neurovascular unit in the fovea. With this in mind, we made a study to assess the qualitative and the quantitative changes using OCTA in patients affected by full thickness macular hole. In agreement with the literature, we saw a reduction in the phase area at both the superficial and the deep plexus after surgery, and it was correlated with best corrected visual acuity. Moreover, we found an increase of the vessel density both for the superficial and for the deep plexus during the follow-up. And compared to controls, the eyes after macular hole surgery had a tendency to have higher vascular density in the superficial plexus, but lower density in the deep capillary plexus. Using OCTA, we found that the deep capillary plexus vessel density was the most important parameter associated with the visual recovery. In other words, the wider the vascular density is at baseline, the better the third month visual recovery is. So, what is the role for OCTA in vitreoretinal interface surgery? Can we do without it? Of course, we can see, we know that the most important prognostic factors still come from structural OCT. But we should broaden maybe our view and include multiple measurements from other techniques such as OCTA in order to have a quantitative evaluation of vessel density and a phase assessment that may serve as a potential useful prognostic factors. But maybe the next step will be a connection with the function. Technologies that connect structural technology with the functional ones. As we know, we have today we have many structural techniques, but not so many easy functional techniques. But we absolutely need, mostly in before and after vitreoretinal surgery, to know the functional consequences of the abnormalities detected using high resolution. We made a study to use an integration between structural imaging techniques and functional imaging techniques such as microperimetry. We made an overlapping between two retinal sensitivity maps obtained by microperimetry and OCT angiography map using OCTA. And by automatic software. And we can see that there is an absolute scotoma in the center corresponding to the macular hole, and additionally rings of relative scotoma extending in the perilesional area correlated to the cystic spaces. We measured the cystic cavity area, and we found it was correlated to the baseline best corrected visual acuity, and the cystic cavity area was also correlated to the retinal sensitivity. In other words, larger macular holes were associated with a wider cystic cavity extensions and lower best corrected visual acuity and lower retinal sensitivity. We found a similar correlation before and after surgery. So we can see that this overlapping between functional exam such as microperimetry and OCTA and fast OCT can show us the correspondence of vascular findings with the retinal sensitivity. So, of course, our retinal imaging is changing, and maybe OCTA is changing our approach to some diseases. Of course, we have to say that after first phase of great expectations, we passed through a phase of disillusionment, but we need to reach a real phase of productivity, conscious of the advantages and the limits of these techniques. We have to know that the OCTA has been added to the top 5 innovations improving efficiency in today's retina practice. So, in conclusion, is there a clinical use for OCTA in vitreoretinal interface macular disorders? We can see just 2 cases. The first case is a case of a patient referred to us for surgical evaluation. She had a lamellar macular hole with a visual reduction. She complained recent onset of metamorphopsia in her left eye, and the B-scan OCT shows a lamellar macular hole and a finger-like hyperreflectivity in the subfoveal region. And it was very easy to perform and very rapid to perform an OCTA that shows very well the presence of 2 neovascular membranes. This was very easy, was very rapid, and this allows us to change our therapeutic approach, of course. In fact, we choose to make intravitreal injection, and we can see the disappearance of neovascular membranes after one injection. So this is another case of a patient affected by epiretinal membrane stage 3 with very evident ectopic inner foveal layers. A female with complaining with a metamorphopsia for 1 year, and we can see that the preoperative OCTA shows no phase visualization or a very small phase, vessel tortuosity, and areas of non-perfusion. We noted a reduction of this feature on OCTA during follow-up, but we saw the persistence of a smaller phase during the follow-up. we can see that the visual acuity does not increase so much, although the B-scan OCT shows a correct recovery of retinal layers. So this case supports the observation that a smaller pre- and post-operative phase area correlates with the lower post-operative visual outcome. And OCTA shows also an area of non-perfusion in the deep plexus that may, in the same case, that may correlate with the low improvement of visual acuity too. Preoperative diameter and the visual acuity, but we can see that 2 months after surgery, a correct recovery of retinal layers is evident, but we have a very different outcome. And the macular hole with the worst postoperative visual acuity had the lower vessel density. So in conclusion, really in conclusion, as we know in medicine, we need to take measurements. We need to have some quantitative biomarkers. Therefore, we can say that OCT angiography gives us the possibility of studying in a non-invasive way some quantitative parameters that could be proposed, maybe, if further study will confirm these results as a new diagnostic biomarkers in many retinal diseases, including surgical diseases. In particular, we have seen that it may be useful to evaluate the patient before affected by vitreoretinal interface disorders before and after surgery using phase assessment and the vascular density measurements. The next step maybe will be the structure function correlation. However, all new technologies, we have to remember, need to be critically evaluated before they transition from research to routine clinical practice. And we should be mindful of this as we look for to embrace multimodal imaging. So thank you so much. Just a last slide about IORIS, our society. I am a member with Sibel of this new Young Ophthalmologist Retinal Imaging Society aimed at promoting research and knowledge in retinal imaging. So if you are interested in having more information, please let us know. Thank you so much.
Thank you so much, Daniela. Thank you for this comprehensive, wonderful presentation about the use of the OCTA in vitreoretinal diseases and surgical retina. We are really learned about how to use the OCTA in the surgical cases, and it will give us a guide to predict the prognosis of vision after the vitreoretinal surgery. So, Sibel, if you have any questions before we open the question for the attendees.
Sibel, yeah, we cannot hear you.
Unmute yourself. Yeah. Okay.
Just I want to thank Daniela for this great comprehensive presentation. I learned a lot, and probably I will fit these all together into my practice, my surgical practice. Thank you so much.
Thank you. Thank you so much.
Okay, any questions from attendees? Tawfiq, in the chat box.
Doctor, there is no question in the chat box. I think
anyone who want to ask Dr. Daniela can unmute yourself. Okay, Daniela, so according to your presentation, should we use OCTA in every case of surgical retina to assess, as you showed us, the superficial and deep plexus? And what are the biomarkers to predict what is the correct time for the surgery for such cases like the VMT, epiretinal membrane, etc.?
I think that it's useful to integrate OCTA in evaluation of patients affected by vitreoretinal interface disorders before surgery and after surgery. Why? Because the OCTA is integrated in many instruments that we use to make a normal B-scan cross-sectional OCT. So we have we can use the same, we have to use the same instrument. So if we have at disposal this instrument that the OCTA, I think that it could be useful to add some minutes to take OCT angiography. It takes some minutes. It's not so fast. Sorry, can you see me?
Yeah. Okay, yeah.
I think that it's important mostly after surgery to evaluate the deep capillary vascular density after surgery, vessel density after surgery, because sometimes it can help to understand the different visual outcome. As I showed you, I have shown with the case of a macular hole. It's very interesting to see that in some cases, even if we have the same anatomical recovery, anatomical outcome, we have a different vessel density, mostly in deep capillary plexus, and this correspond to a different visual outcome. So I think that we have to use more and more this technique to understand the advantage and the limits of this. But we have the possibility to study in a non-invasive way the vascular involvement that commonly we don't assess before vitreoretinal interface surgical disorders.
Okay, so my second question, in case of diabetic retinopathy, how we can look to these OCTA markers, biomarkers, because sometimes it may be caused by the diabetic retinopathy rather than causing by vitreoretinal disease. So how I can look to these biomarkers in the presence of diabetic retinopathy? How can I predict?
Yes, it's not easy because we have to remember that often in diabetic epiretinal membrane we have a mix of alterations induced by epiretinal membrane and, for example, macular edema, diabetic macular edema or intraretinal cyst. So it's not easy, and as I show you, not all glitter is gold. So it's we have to be careful, mostly in diabetic patient, because the evaluation of diabetic macula is not so easy with using OCT angiography. But it can be useful to see, to assess the phase area also in these patients, and we have to remember that the enlargement of the phase area in this patient correlates with the diabetic retinopathy severity and the grade of macular ischemia. So also in these cases, it could be useful to add some minutes to perform an OCTA.
Okay, thank you very much. Any questions from the attendees? You can ask and unmute yourself. Okay.
Dr. Fawaz?
Yes.
I think
yes,
we have a question in the chat.
Yeah.
Do you have access to the chat box?
Yeah. Okay. 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 So, Dr. Agoto, good evening. Do do NFLS have an important impact in postoperative visual acuity?
DOMFL has not so important impact in postoperative visual acuity, but the impact is mostly on the retinal sensitivity around the fovea. It could be interesting to do a study of the vascular changes induced by DOMFL after surgery. That is a very common findings after surgery, and the retinal sensitivity. So I think that DOMFL is very common. We need maybe with a structure function correlation to study if they have an important impact on retinal sensitivity and of consequences on vascular and on OCTA and so vascular changes.
Okay. Any questions from the attendees? Okay, so we can now finish our scientific webinar.
You're done.
And I wish really thank Dr. Sibel and Dr. Daniela. We really learned so much from your presentations. I am personally learned much information about the pachychoroid disease, about the OCTA in surgical retina. This is another perspective for me because I always am thinking about the OCTA just in a medical retina. But now you show me in your wonderful presentation about how we can apply the OCTA in a surgical retina. And also we learned so much about the pachychoroid disease and what is the best way, the best approach to such diseases. And thank you so much for your kind acceptance of our invitation to our scientific webinar. And I wish to thank all the attendees, all the colleagues that joined us this night from Jordan, from Iraq, from Europe, from United Kingdom, from all the other parts of the world. Thank you so much and good night.
Thank you.
Thank